Comprehensive care for joint replacement, or CJR, is a really complicated program. Basically, what Medicare has said is they're going to take all care related to DRGs 469 and 470, and they're going to pay a hospital based on the total costs that are incurred in the 90 days following the patient's discharge. Medicare is going to take data, historical cost data, and come up with a target price that the total bundle of care should cost. If the hospital is able to provide that care at a lower rate, it receives extra payments. If it's at a higher rate, it's going to owe money back. Now, a couple of things about this are counterintuitive. First, the bundle of care includes a variety of things over which the hospital is going to have no control. So, first of all, things like the physician's services, physical therapists, and skilled nursing facility costs all go into the bundle. But at least those seem rationally related to the costs of joint replacement. Also going into the bucket are things like chemical dependency and mental health treatment. So if a patient were to go in for chemical dependency to treatment 60 days after they receive a joint replacement, the hospital is going to have those expenses put into its CJR bucket. So ultimately, the hospital's responsible for some things it can control. If it can lower, for example, the cost of an implant, it will see those savings. But it's also going to be responsible for things well outside of its control. The last factor that goes into the payment, there are going to be some quality of care and patient satisfaction metrics that can both increase the payment that the hospital receives or in some cases completely eliminate it. If a hospital isn't in the right, doesn't have the sufficient quality performance, generally being in the top 70% of hospitals across the country, then they're not going to be eligible for any additional payment under the CJR program. CJR gives hospitals an incentive to think creatively. I think a lot of people will focus immediately on the possibility of doing some sort of gain-sharing relationship with physicians. And it's a good idea and one that can be explored. But it's also possible to do other things. You can enter a gain-sharing relationship with a skilled nursing facility or with physical therapists or some other relationship designed to lower costs. Obviously, another piece of low-hanging fruit are implant costs. That's probably one of the biggest expenses for the hospital inpatient care that can be lowered easily. And finally, you look at other ways of providing the care more efficiently. And the goal of the gain-sharing relationships is to bring everyone into the table to focus on trying to make that the total care more efficient and lower cost.